There you go.
Should I start?
Just give us a few minutes. People is connecting now.
Okay.
I think 7 p.m. we can start.
Sorry?
7 p.m. I think we can start.
All right. Now?
Yes.
Okay, good evening, colleagues. Welcome to episode 3 of the International Leadership Series in Clinical Care. I am Dr. Maria Aponte, a international business manager from the Panama Clinic, and also representative for Latin America and the Caribbean from Philadelphia International Medicine. It's a pleasure to be with you today in this discussion. It's important to mention that Philadelphia is known as a city of education and medicine because it says that 6 from 10 physicians of the US have been trained in this city. Also, we have 7 medical schools, 22 nursing schools, 2 dental schools, 4 pharmacy colleges, and 100 hospitals. So as you can see, it's an amazing city where this part of medicine has been developed. Also, it's important to mention that Philadelphia International Medicine has 3 scopes. First of all, it has to do with clinical treatment. And with this, I mean that we receive patients from several parts of the world that come to our different institutions, and we make sure that they have everything they need in order to receive their treatments. Also, we have medical education, meaning that doctors from other parts of the US and also from abroad come and have observerships with us in the hospitals. And we also have consulting services. We help other institutions around the world in educational tools, in quality assessments, and in health improvements. And that is why we are associated with the Panama Clinic too. Philadelphia International Medicine is owned by 3 academic centers, which are Jefferson Health, Fox Chase, and Temple Health. And these are the biggest and leaderships of the US, because not only we have 3, which are really affiliated with us, but we work with the other ones that you will see in the screenshot. Important to mention that the Panama Clinic is a hospital that has been conceived to be acknowledged as a regional leader in medical and hospital care services. It's integrated to a complex Pacific Center. It's a multi-purpose building complex where visitors can do a lot of things while being in the hospital. For example, we have a high scientific level and state-of-the-art technology hospital. We have also a building with all the doctors' offices. We have the Marriott Residence Inn Hotel that is conceived to receive patients that will stay for a long period of time within our institution. We have also like a mall and a business center. Our main goal is to provide differential healthcare services through our individual focused care with patients' experience and safety as our priority. We also have a very important area of support area. And also we have operating rooms that you can find only in very specific hospitals around Latin America. That is the importance of being part of this process. Hey, Dr. Alvarado.
Very good afternoon. Good evening
evening.
to all of you. Yeah, here just leaving the operating room, so that's why I was a little bit late. Hi, Adam. Welcome.
No, it's a pleasure to have you here. So I am going to give you the speech. You are our host. So Dr. Angel Alvarado, welcome, and please introduce our speakers today. Thank you very much.
Yeah, well, first of all, sorry for the delay, but we've had a very busy schedule today, thanks God, and I was warm welcome to Dr. Manduley, who is one of our associates here in the Instituto de Urología, and for sure Dr. Reese, who is our special guest today, who is a real expert in the topic of active surveillance, which is one of the hottest things now in the management of prostate cancer. Interestingly, we are going to share some of the experience on this side of the world by local authority and regional, I will say, as Alejandro Manduley is. He's a very well studied in the topic and very highly interested on it in prostate cancer particularly. So he's been helping us with that. And for sure, Dr. Reese, which is a professor at the in oncology in the system at Temple University, and has a very interesting background, especially in the topic of in the field of prostate cancer. So I will say, Dr. Manduley, the audience is yours, so welcome and thanks for participating with us in this webinar today.
Well, thank you, Dr. Alvarado, for the introduction, and I will share the screen. I think it's there. And okay, there you go. Do you see my screen? Yeah?
Yes, sir.
Well, thank you, Dr. Alvarado, and thanks for the Philadelphia International Medicine for this opportunity. Today, first of all, my disclosures for this topic of the applications of active surveillance of the active surveillance concepts in Latin America urological practice. First of all, I'm a urologist. You know, I'm not a medical philosopher or an epidemiologist, and we're going to talk about concepts. So that's my first disclosure. Second, in this kind of presentations, you will have opinion. So there's some things that you can agree or not. And the third one is the Latin America health numbers are not as good as we would like. So we cannot give you that a lot of information in numbers. And none of my disclosures is related to active surveillance or any of the related industries to it. Well, when I was asked to prepare something directly on Latin American active surveillance, first thing I did was this search in PubMed of active surveillance, and I started looking for what it gets in the results. And two things come to my mind. First is that this is a very young knowledge. We have 95% of all the papers in this century, in the last 20 years. And the second, that is a little of lateral thinking, is that I wrote active surveillance and I get results for active surveillance for prostate cancer. So it's complete in prostate cancer. And I realized that active surveillance is a situation that we have in prostate cancer that we don't have in the rest of oncology, except in very few exceptions. One of those is also in urology, that can be kidney cancer, but it's very not often that in oncology we have an adenocarcinoma that we diagnose localized with the option to cure, and we decide to do nothing. So what's so unique about prostate cancer? It's a disease with a unique pattern in oncology. Well, no, right now we all know a lot of the molecular biology of prostate cancer, and we know it's very resemble the pathways to all the oncology, or maybe it's our knowledge, our impact in society and socioeconomics of the prostate cancer that makes this disease so special. It's like a Schrodinger cat effect, you know, like we act on it and we change it. Just like an open question, you know, let's see what unique things we have about prostate cancer. Another unique thing is, oh, I can't get the next slide. Let me see. Another unique thing is that it's a very young cancer. It's a young cancer because it's an old man disease. And in this chart, you can see that only in the 20th century is when the human beings started to live more than 50 years. So we start to have a population in which prostate cancer would have an impact. And you can say, well, like all the oncology is a young specialty. It's a branch for internal medicine that developed in the 20th century also. And yes and no, because we know a lot of cancer from thousands of years ago, pancreatic cancer, osteosarcomas, but we don't know a lot about prostate cancer. We have very little information of prostate cancer in the old times, and it's because of this. It's a young cancer for humanity. Another thing that is very unique is the ADT. ADT was really a pioneer. It was something that was discovered a lot early than it should. It was in the 1940s that they started spreading this. In the 1940s, we have nothing for cancer. We have nitrogen mustards, some people using methotrexate. We really have nothing. And these people come with a treatment that with a stage 4 adenocarcinoma gives you 24, 30, 36 months of overall survival. So this was something very different about how the society confronted prostate cancer. And I think to being a pioneer is very good for some things, but it's not as good for others. And in prostate cancer treatment, the ADT remained as a gold standard alone for a long time, for more than 40 years. So maybe this early discovering or this early using of ADT was not so good in the long run. The second point is that we get around the same time the development of great local treatments with surgery and radiotherapy in the same time in the history of prostate cancer that we start getting the early patients. We have the PSA era with a very good local treatment with radiotherapy and surgery with less complications of both of them. So we were very happy. We were curing a lot of people with localized prostate cancer. And we have this incredible news in 2008 that we have a movement against this. So I'm not gonna go deep in the studies, the pivot and the protect and the other studies that came after in which they supported this. We all know that they redo the statements for something less aggressive that don't screen anybody. But how can you have this very aggressive disease that we all see a lot of people dying of with very good treatments, and you're gonna say that you don't have to treat them? Well, I think one of the pillars of this is the heterogeneity of the disease. Maybe not the answer, but one of the answers. And in this, you have also a pioneer stuff with prostate cancer, that is the Gleason score. Gleason score is from the 1960s, and it has the same effect. You have something very good, so you stop looking. And this is one cancer that for a lot of time, we were not interested in differentiating more than with Gleason. Everybody was like, okay, that Gleason 4 and Gleason 5, these are the bad guys. We're pretty sure that this patient is not going to do well. And this is the guy that we really don't know what it is. The Gleason 3 is a pattern of cancer that you see in the normal stain of hematoxylin eosin. And you can have this, you can have a very locally advanced cancer with no mets, or you have a tiny spot of cancer in the prostate with a lot of visceral mets. You can have a lot of people dying of other conditions, very old, with the Gleason 3 prostate cancer inside. And you can have men dying at 50 years old from Gleason 3 prostate cancer. So this disease is the one that we're very far from characterizing. And something that, again, with a lot of thinking, right now it's very, we have a lot of papers on prostate cancer heterogeneity, but since Gleason, we can tell we don't describe the Gleason with one number, we describe it with two numbers. So from the beginnings, he was telling us this disease, you can coexist the different patterns of prostate cancer in the same patient. So right now, this guy, the Gleason 3, can be the bad guy or the good guy, and we don't have the tools yet to know which disease it is. So this is where active surveillance can have a spot, and this is the sweet spot for active surveillance. You can see in the actual guidelines, it's recommended for very low risk, and in some cases intermediate. And the main point of this is Gleason 3. Is this, what I'm gonna say is an opinion. I'm pretty sure that when we know how to characterize this correctly, the active surveillance would lose some of the protagonism of this spot that right now is the spot for active surveillance. Well, talking a little bit more about heterogeneity. This is a very nice paper in Science, have some years right now, about the different kinds of heterogeneity. It's the intratumoral, this one that Gleason was giving us from the 1960s, that you can have different clones in the same cancer. The intermetastatic one, that it comes from the issue that if you have different clones in the same cancer, you can have different metastases from each of the clones. So they're going to be different. The third one is that the metastasis can by itself develop different clones, even though more in the when you are given some treatment to it. And one that is not taken in account is the fourth one, the interpatient. And the interpatient heterogeneity is what really describes our society. It depends on our society, the prostate cancer in our society. It depends on biology, by far and for sure, in the genetic pool of each society, but it also depends on the socioeconomics and the health access of each society. So this gets very important, this interpatient heterogeneity, for describing the real outcomes. When you have a paper and you have a Kaplan-Meier chart, what you have is this. What happened to that genetic pool of prostate cancer when you treat it this way or this other way? So why is this important for an active surveillance program? Well, I think this is especially relevant in active surveillance, because in active surveillance, you have this spot of, I'm not pretty sure of what disease is this, in which I have to make an impact. So in the US, we have this expected cases for 2020. This gives us a raw mortality of 17. Raw mortality is a number that comes from the deaths of the disease divided by the new cases. It's impacted by a lot of factors. But in prostate cancer, the main factor is well characterized. We see that in Panama, we don't have good numbers because we're Latin America. This is 2017, is the most recent I have. I have 300 deaths and 800 new cases. So my raw mortality is 35. It's more than the double than the US. And this is how it behaves in Australia, New Zealand, North America, Northern Europe, between 10 and 15. This is how it behaves in Latin America, Central America, South America, and the Caribbean, between 23 to 40, and Panama is just where it should be. These are statistics for the global can. So what I'm saying with this raw mortality effect, as I said, it can be affected with a lot of factors, but it's very accepted that the most important factor is the M1-M0 relationship of your prostate cancer in your society. If you have more M1 diagnosis, you're gonna have a lot of more raw mortality than if you have M0 diagnosis. This is the overall survival. I think everybody knows this. When you have localized disease, you have a very good outcome. When you have metastatic disease at the diagnosis, you have a very bad outcome with an overall survival right now around 40, 44 months if you get the best treatments. So with this reality in Latin America, I'm telling you, we have a very high M1-M0 relation. And subsequently to this and other factors, but mainly to this, we have a higher mortality, higher like double, and in some places more than double. So should we encourage active surveillance in this scenario? Or this is a first world problem and not a Latin American problem? Well, I really think that this reality in Latin America with this M1-M0 relationship and subsequently higher mortality that I'm showing you this with this example, the idea that we should really get is that we should strongly encourage screening. Right now, if you want to call it like that, our third world problem right now is that we have to lower our M1-M0 ratio. And for doing that, we have to screen. And if we screen, and I really hope we will, we are getting very good cancer policies in the different places of Latin America. So we will screen and we will detect and we will change this ratio. And then we will have the first world problem of overtreatment or not. That's where doing this wisely is what can make a change. What we can learn from the US, from Australia, New Zealand, and from Europe, I think that what we really should learn is that overdiagnosis is not the problem. Overtreatment is. So we will have this problem because if we screen more, and we have to screen more to really solve our main issue right now, that this is this very high M1 diagnosis that we have, then we will have more patients in this sweet spot that really will benefit from active surveillance. We have to prepare ourselves. Well done active surveillance is an unmet need right now in Latin America. And I really think that this is not, this is a process. This is something that takes time and goes gradually. We will not one day with an M1-M0 ratio of 50-50, that's very high, that is our reality. And the next month, we're gonna be like the US with 5% localized, 5% metastatic and 95% localized. This will be a process, and this process that will take years, we will start having more patients with low risk and very low risk prostate cancer with Gleason 3, and we will not know if this is a very aggressive disease or not. So we will have to do a well done active surveillance. In this, we have to say that we don't treat averages. We have to get the information from the trials that it's about averages and populations. We attend patients, and it's not fair that this patient with good access to good medicine will be not well treated because in my country I only do treatment or not. So we have to prepare for this. And this is like the first concept I want to talk about Latin America's situation respectfully to active surveillance. And the second one is the concept of observation. And this is because I see a lot of colleagues and in a lot of family physicians talking about this observation for prostate cancer.
3 more minutes, doctor.
Yeah, this is a very short concept. In 3 minutes, I can tell you the active surveillance is a patient in which we have a localized adenocarcinoma, low risk or very low risk, that if he progresses, then I will convert my approach to a curative intended treatment. Meanwhile, observation is a patient that if he progresses, I will determine if I start a palliative ADT. That's like the main difference. In the clinical implementation, they have a difference also. That is when you are doing active surveillance, and I will not talk about this. I think Dr. Reese is gonna give you a master class about this. You do rebiopsies and MRIs, and in observation, no. Like for example, observation is this patient that's 85 years old that for some reason have a biopsy and have a PSA in 35, but it's completely asymptomatic. So this is the patient I observe. Sometimes I don't even stage this patient. I stage depending of how it goes. And this how it goes is very interesting that in observation, that is this patient that I'm talking about, there is almost no protocol, no standardized criteria. Of some people say you should start with a PSA in 20 or a PSA in 50 or in 100. Right now, we don't have a protocol for observation, for deciding this patient with 85 years old, a 3+3 Gleason score, and a PSA in 35, when I start ADT, if I do. But right now, the most accepted tool we have is the PSA doubling time, situated in 12 months, and all the information is from studies that were for other stuff, and we take the data to try to say, when should I treat this patient? In Latin America, in the real world experience, they can be similar. Sometimes we don't have that access to seriated MRIs or seriated biopsies, but if we want to do good medicine, we have to have the concept that are completely different. So the take-home message for this application of concepts for Latin America, first of all, the last one, active surveillance and observation are completely different concepts. One is a patient that I am trying to know what disease he has, and if I realize he has the bad prognosis one, then I treat him on time for preventing complications. The other one is a patient that I really think he will not progress, and I will palliate only if he progresses somehow. In Latin America, they can look alike, but it's a responsibility of us, the doctors, that to have the concepts clear so we don't mix them. And the second point is that active surveillance is the best answer for the low risk and the very low risk prostate cancer. That yes, maybe in Latin America, right now is not a very big percentage of our patients, but if we do what we have to, and what we have to right now is to lower our M1, M0 radio, we have to screen. And if we screen, we will have these patients. So there's no such a thing as overdiagnosis. What you can have is overtreatment. You have to know what to do with the information. And for this, I think the correct active surveillance protocols are the answer. So in this, I can tell you that this is a very old phrase from Voltaire. Right now is the time for Latin America learn from the experience of others. We have the experience of the US and Europe that for a lot of time they overtreated because they overdiagnosed. Right now, I think we're in the era that we can overdiagnose. There's no such a thing as overdiagnose. Information can never be harmful. We have to know what to do with that information and learn in the experience of others. Well, thank you very much. I think I'm on time. This is what we want to share with you.
Uro-oncologist also. He's the chairman of urology oncology at the Temple University at the Lewis Kaplan Hospital. So welcome, Dr. Rees, and the audience is yours. And thank you for accepting the invitation to share some of your knowledge with us and experience.
Great. Well, yeah, thank you very much for having me and for that kind introduction. I'm happy to be able to speak with you today. Let me bring up my slides here. Okay, can you see my screen? Yes, okay.
Yes, sir.
So I have to say that last talk was actually very interesting and eye-opening for me because as Dr. Mandalay said, I think here in the United States, we are coming at this problem from a very different perspective. You know, as most of you are probably aware, PSA screening was really widely embraced in the United States, beginning probably in the late 1980s, early 1990s, and into the early 2000s. And we really did have a problem with, and I agree, you know, not so much a problem with overdiagnosis, but overtreatment. For decades in the United States, anybody that was diagnosed with any form of prostate cancer, whether it was a higher risk cancer or the lowest of the low risk prostate cancer, most of those patients were undergoing surgery, they were undergoing radiation therapy. And we eventually learned that, you know, we weren't necessarily helping those patients because most of those patients, their cancer was not going to progress or harm them anyway. But what we were doing was subjecting them to quite a bit of morbidity from the treatments that we were administering. And so that was what led to a lot of the backlash in the United States against PSA screening, against screening for prostate cancer in general. I think that's what led to a lot of the US Preventative Services Task Force recommendations that were mentioned in the prior talk against PSA screening. So I think active surveillance really is a good solution to the problem of overtreatment. And you know, as Dr. Mandalay said, this is not watchful waiting. This is not observation. This is not, we're going to completely forget about your cancer. This is, we're going to follow you very closely. And if you do show signs of disease progression, we're going to intervene at that point. And our chances of curing the cancer should be the exact same, you know, if we intervene in a delayed fashion as it would have been had we treated you directly up front. So for my talk today, though, what I wanted to focus on is exactly which patients are the ideal candidates for active surveillance. And I'm going to focus a little bit on some of the work that I've done on sort of expanding the criteria that we use to select patients for active surveillance. Let me see if I can get my slides to advance. So just as a way of an outline, I'm going to begin by reviewing the existing active surveillance eligibility criteria. And I'm going to walk you through what I think are some of the problems with these criteria. And then in the second part of my talk, I'm going to review some work that I've done with others on developing new criteria that we can use to identify men who are potential candidates for active surveillance. And I'll show you that this work suggests that there are some men with intermediate risk disease, primarily low volume Gleason 3+4 on biopsy, who traditionally would not have been considered candidates for active surveillance, that these criteria say, yes, actually we can perform surveillance in these men. And so because of that, I'm going to end my talk by discussing some of the literature on active surveillance outcomes among men with intermediate risk disease to see whether or not, you know, this is in fact safe, or are we potentially putting these patients in harm. So unfortunately, there are no universally accepted criteria by which we determine which patients are a good candidate for active surveillance. Instead, what we have are a wide range of different criteria that have been proposed by various institutions across the world. And so this table just summarizes some of the eligibility criteria that are most widely utilized. And you can see that there's quite a bit of variability in these criteria. Particularly some are quite strict and others are quite lenient. And so in general, I've arranged this table where the strictest criteria are at the top of the table, the most lenient or the most liberal criteria are at the bottom of the table. So you can see the Johns Hopkins eligibility criteria, for example, they are quite strict. So at their program, the only candidates for active surveillance are men with clinical stage T1C disease, biopsy Gleason score of 6, PSA density has to be less than 0.15. They have to have 2 or fewer positive biopsy cores and no more than 50% involvement of any single biopsy core. So you can see that given these criteria are quite strict, there's a relatively small number of men who would be considered active surveillance candidates at a program like Johns Hopkins. In contrast, if you look at the bottom of the table, the Royal Marsden criteria, these criteria are quite lenient. In general, they say any man with Gleason 3+4 or less, as long as your PSA is less than 15, and as long as you have no more than 50% involvement of any single biopsy core, then you're potentially a candidate for active surveillance. And so what are the implications of these eligibility criteria? So I think there can be, two extremes. So if your eligibility criteria are too strict, what you're going to have is you're going to have relatively few men who would be considered for active surveillance. And therefore, many men who probably would have done just fine on active surveillance are going to be treated unnecessarily. And then they're going to be subject to the potential harms of our definitive treatment modalities. And this is basically the problem of overtreatment that I think we're all aware of. In contrast, if your eligibility criteria are too lenient, what you're going to have is you're going to have a very large number of men who are potentially on active surveillance. And unfortunately, some of these men likely have higher risk disease, and it's more likely that these men could have disease progression or even develop metastases while on active surveillance, which clearly is an outcome that we want to avoid whenever possible. So in the ideal world, the ideal eligibility criteria would sort of balance these two extremes. And what they would enable is they would allow for an appropriate number of men to be involved in active surveillance programs, while also minimizing the risk of disease metastasis or progression. So the problems about these various eligibility criteria is, as I've shown, there's a lot of variability among the different criteria. Some are quite strict, others are too lenient, and those come with problems. And then a second big problem is all of those criteria that I showed in that table a couple slides back, they're all based on expert opinion, not data. And I think that's a problem because clearly we have a lot of data on low-risk prostate cancer now. We should be able to develop eligibility criteria that are actually based on empiric data. So what I have been working on recently with some of my colleagues is using objective data to develop sort of more rational eligibility criteria for how we can select men for active surveillance. And the way we did this is we utilized data from what's called the Pennsylvania Urologic Regional Collaborative, or PERC. And what this is, it's a data sharing collaborative of 11 urologic practices across the state of Pennsylvania and New Jersey. Temple Hospital, where I practice, is part of this collaborative. And it's really quite a powerful data set. Currently, we have over 12,000 prostate cancer patients in the database. So it really allows us to do some powerful and effective research using these data. So what I wanted to do is I wanted to use adverse pathology at radical prostatectomy as our outcome of interest. And we basically wanted to identify variables that were present at diagnosis that were predictive of adverse pathology. So if we could identify men at diagnosis who were likely to have adverse pathology, we could rule those men out of our active surveillance program or recommend that those men not undergo active surveillance. In contrast, if we can find what variables are predictive of favorable pathology after radical prostatectomy, then those would be the men that we probably would want to enroll in active surveillance and we should encourage to undergo active surveillance. So for this study, for that reason, what we did is we identified only men with low or favorable intermediate risk prostate cancer as defined by the American Urological Association. And we looked at only men who underwent radical prostatectomy up front. So these were not men who underwent active surveillance. We then aimed to identify factors present at diagnosis that were associated with adverse pathology at radical prostatectomy. And we defined adverse pathology as a pathologic Gleason score of 4+3 or higher, a pathologic stage of T3 or greater, or positive lymph nodes at radical prostatectomy. And then we use these factors to develop what we call the PERC active surveillance eligibility, or the PERCASE score. So this is just a schematic of our study. We had a little over 1,100 patients with low and favorable intermediate risk prostate cancer who underwent radical prostatectomy. A little bit over 1/3 of those patients were found to have adverse pathology. And then we used those data to develop this PERCASE score. So these are the results of the final multivariable model looking at factors predictive of adverse pathology. So you can see in our model, increasing age was associated with a higher likelihood of adverse pathology. Not surprisingly, the higher your PSA, the more likely you were to have adverse pathology. Biopsy Gleason score was associated with adverse pathology, and the maximum percent of a biopsy core positive likewise was associated with adverse pathology. And based on the strength of the association with each of these variables, we assigned a score. So you can see, for example, a biopsy Gleason score of 3+4 was most strongly associated with the risk of adverse pathology. So that would give you a score of 3, whereas an age greater than 65 was less strongly associated with adverse pathology. So that would only give you a score of 1. So here's the final scoring system. So basically, when you're seeing a patient in the office, you can look at their age, their PSA, their biopsy Gleason score, the percent of the maximum percent biopsy core positive, and you can assign that patient a score. And this PERCASE score ranges from 0 to 8, with lower numbers indicating a lower risk and somebody who would be a better candidate for active surveillance, and higher numbers indicating a higher risk patient who would be less inclined, or we would less likely encourage to undergo active surveillance. So basically what we did is we assigned every patient in our database a PERCASE score, and then we looked at the rate of adverse pathology for each score group. So as you can see, there was a stepwise increase, whereas the PERCASE score increased, there was a corresponding increase in the risk of adverse pathology for each group. We then decided we were going to group these patients into different groups in terms of how good of a candidate they were for active surveillance. So we said, okay, those patients with a PERCASE score of 0, those are going to be considered the ideal candidates for active surveillance. Patients with a score of 1 to 3 would be considered good candidates for active surveillance. Patients with a score of 4 to 6, these patients, you see they have a 40 to 45% likelihood of adverse pathology. So these patients would really be considered borderline candidates for active surveillance. And anybody with a score greater than 7 really has a high risk of adverse pathology and really probably should not be considered a candidate for active surveillance. And so here we see the risk of adverse pathology in these different groupings that we established. And again, you can see as you go from ideal risk to good risk to borderline to not a candidate, there is a stepwise increase in the risk of adverse pathology at radical prostatectomy. So we wanted to see, how do these criteria that we develop, how do they compare to a lot of the other active surveillance eligibility criteria that are widely utilized? So we created an ROC curve, which looks at how powerful this model is in predicting adverse pathology. And we compared our model to the UCSF active surveillance eligibility criteria and the Johns Hopkins active surveillance eligibility criteria, which are 2 of the most popular criteria used in the United States. And you can see that our PERCASE score, which is the red line, has a significantly greater area under the curve compared to these other 2 scoring systems, indicating that our model outperforms these other 2 scoring systems in predicting the risk of adverse pathology at radical prostatectomy. So we were encouraged by that, but we then wanted to go ahead and validate these data using a completely separate data set. And so luckily we have a fairly strong collaboration with a different quality improvement collaborative that many of you may have heard of. This is the Michigan Urologic Surgery Improvement Collaborative. And this collaborative is very similar to the PERC collaborative that I participate in, but the Music collaborative actually is much older and therefore has a much larger number of patients. But we were able to obtain the data from the Music collaborative, and then we use those data to validate our PERC score using the Music data. So for this validation cohort, we looked at 6,837 patients from the MUSIC Collaborative, again, with low and intermediate risk prostate cancer who underwent radical prostatectomy. And what we found is very similar results. This is the ROC curve using the MUSIC data. And again, you can see our per case score in red has a greater area under the curve than the UCSF eligibility criteria or the Hopkins eligibility criteria, indicating that again, in the MUSIC data, our scoring system seems to outperform these other widely utilized active surveillance eligibility criteria. So we were encouraged by that, and so we started to use this scoring system in the Pennsylvania and New Jersey region. But one thing that you'll notice, so on the table on the left, this shows our scoring system, and then on the right, this shows whether they would be ideal, good, borderline, or poor candidates for active surveillance based on the scoring system. And so some of the feedback that people gave me is you'll notice that you could have a patient with a biopsy Gleason score of 3+4, and traditionally, at least in the United States, these patients have not been considered good candidates for active surveillance. But if your other disease parameters are favorable, this would only give you a score of 3, which would put you in the good group, or it would indicate that you could still be a good candidate for active surveillance. And you could even have a patient that had a biopsy Gleason score of 3+4 and a PSA in excess of 10. And again, if your other parameters were favorable, this would only give you a score of 5, and that would say that you still could be considered a candidate for active surveillance, although you would be a borderline candidate. So I got a lot of, maybe not criticism, but constructive feedback saying, hey, listen, should these intermediate risk patients really be considered for active surveillance, or is that potentially too risky? And are we putting these patients at risk of poor cancer outcomes by monitoring them or putting them on surveillance instead of taking them straight to surgery or radiation therapy? So to answer this question, I looked into the literature at active surveillance outcomes for men with intermediate risk prostate cancer. And so this is a nice review article that was published in Current Opinions in Urology in November of last year. And basically this summarized data from 5 relatively large studies looking at active surveillance outcomes in intermediate risk patients. And you can see in this red box, this shows the number of intermediate risk patients in each of these studies. And so these studies were relatively robust. Each study had at least 100 intermediate risk patients, and one study had as many as 223 intermediate risk patients managed with active surveillance. And in this red box, they show the cancer-specific survival for low-risk patients on the left, and the cancer-specific survival for intermediate risk patients on the right. And it's hard to kind of tease out the actual numbers, but basically what it shows is that cancer-specific survival for intermediate risk patients is slightly less than low-risk patients, but not drastically different. So this would indicate that cancer outcomes for well-selected intermediate risk men on active surveillance appear acceptable. One thing that they did notice, however, is on the far right here, they looked at treatment-free survival for intermediate risk patients. And what they found was that treatment-free survival was relatively poor, meaning that a relatively large number of these patients were initially placed on active surveillance, but then showed evidence of disease progression over time. So were then transitioned off of active surveillance and underwent either surgery or radiation therapy or some other form of definitive treatment in a delayed fashion. And that rate of stopping active surveillance and progressing to definitive treatment was much higher in intermediate risk patients compared to low risk patients.
2 more minutes, doctor.
Okay, so basically, to summarize the data for intermediate risk patients, it appears that active surveillance is safe for intermediate risk patients, especially well-selected men. And by what I mean by that is men with a low volume of Gleason 3+4 disease on biopsy. I do feel these intermediate risk patients, this is the subset of men where I think genomic testing can be quite helpful. We use a lot of the Oncotype assay here, which helps further risk stratify these men. And I also think MRI ultrasound fusion biopsy can be very useful in these patients when they undergo surveillance biopsy. We have a number of intermediate risk men who started on active surveillance and then for confirmatory biopsy had MRI ultrasound fusion biopsy performed. And we found a larger volume of intermediate risk disease or even higher grade cancer such as Gleason 8. And we took those patients off of surveillance and moved them on to definitive treatment. So in conclusion, I hope I've shown you today that the existing active surveillance eligibility criteria are highly variable, and they're based on expert opinion as opposed to empiric data. So to solve some of those problems, we developed this per case score, and I propose that as an objective and evidence-based scoring system that we can use to identify men eligible for surveillance. And at least in our preliminary analysis, this scoring system appears to perform better than other established active surveillance eligibility criteria. And finally, I do think active surveillance is safe in men with intermediate risk prostate cancer, but they have to be well-selected men, particularly men with a relatively low volume of intermediate risk disease. So that's all I had for my portion of the talk. Again, thank you for allowing me to speak with you today. I'll stop sharing, and I think we have some time to take some questions.
Yes, talk as usual. One domestic thing is, please, I encourage the colleagues that are attending, please to make their questions using the chat or the slot for questions and answers, and we could transfer that to the speakers. What about MRI alone as a tool for following patients with this PSA and MRI without any fusion biopsy? Any words on that?
Yeah, so I think I wish I felt that MRI alone was safe, because that's one of the #1 problems I have with managing my patients with active surveillance is obviously none of them are excited about undergoing repeat biopsies. But really, if you critically review the literature, I don't think the literature show MRI alone is accurate enough at identifying progressive disease or higher grade disease. I think it can be used as an adjunct, and when combined with biopsy, I think it certainly is helpful. But I don't think we're at the point where MRI alone is sufficient. Others may disagree with me. I mean, certainly there are some high volume MRI centers here in the United States, and their data would show that potentially it may be okay. But I think for the average center and the average practitioner, I would not be comfortable with MRI and PSA alone. I think the biopsy is really integral. Yeah.
Okay. Good, and this is not like a point and counterpoint, but Dr. Mandulay, evidently, he is highly interested in following this kind of treatment for patients, because this is a tool, an additional tool for treatment. You are not just crossing your arms and don't do anything. Simply, you are following the patients and see whether they might need some treatment or not, more aggressive treatment in the future. But then with the per case tool also, do you think, Dr. Mandulay, that it can be adapted to our countries, adapted for the follow-up of these patients? What do you think about?
I think it's a great point to start doing it scientifically and not because of opinion. And for every population is different, and we all have different conditions. You validated it for the US population, and we should validate it here. We have a database of 3 years of low-risk radical prostatectomies, and our upgrade is 82%. From this is a little bit higher than the literature, and in this upgrade, 49% were for Gleason 4 and 5 in patients that preoperatively have 3+3. With this, I cannot say anything. I only can say that we have a little bit more upgrade than the rest. And what I can tell you is that we have to know our population. This is the real gray area of prostate cancer. So we have to know our population to see if we can validate this. And I think it will, but we should do it. We should, for this specific topic, I think we cannot adopt without validating the scores for Panama and for every site that tries to use it. Maybe you adopt it, but you start counting on how it really goes. And if you realize that your patients like your genetic pool is more aggressive, then you don't do it. And maybe you realize the counterwise, that your population is less aggressive in Gleason 4. In Panama, we don't know it. We should not assume.
Yeah, so that upgrading rate is much higher than what we see in the United States. I don't know. it may be differences. I don't know your standard biopsy practice in terms of number of cores taken and how frequently MRI ultrasound fusion biopsy is done. We're seeing a lot. That's much more common in the United States these days. So I think because of that, we potentially have a more accurate sense of the grade of the tumor at biopsy, and our upgrading rate is much lower, and therefore we're probably a lot more comfortable in managing these patients on active surveillance. But I could certainly see the concern if you're upgrading to, Gleason 4+3 or even higher is in excess of 50%, then I could see why there would be quite a bit of concern in putting patients on surveillance.
Yeah, but I think it's a process. It's a process on time. This data is from 2016 to 2018, and 95% of the biopsies are systematic biopsies with no MRI.
Mm-hmm.
So when we start changing that, we're going to lower for sure the upgrade, because we're going to have a better diagnosis at the beginning.
Yeah.
So I think it's applicable in our reality, and I think it's a need because we are going to start having these patients. So we have to have something to give them the right treatment for this.
Well, I will say that we will not. I mean, we do have already patients, several, especially in the private field. I will say, people who is already studied or they read about their diagnosis. In fact, Dr. Leticia Ruiz is commenting here to us, and it's a very valid point. The fact that most patients in public institutions in Panama are not targeted, and biopsies are not targeted in most cases, and most patients do not even get an MRI, which is the practice nowadays that we use in the private institutions. In addition to that, also the access to information and the access to follow-up of the patients in the private field is more accessible, I will say, or more accurate than the patients in the other areas. In the States, it's a bit different. That we always has been blaming the racial mixture that we have in Panama as one of the main factors for the high rate of prostate cancer and the high aggressiveness rate of the prostate cancer. So, but in fact, probably also the late diagnosis, that it's all a factor that should be considered as well. And the fact that the people sometimes they don't want to, or they do not get easy access to the medical facilities, particularly in this public health, not in the other systems. So we until recently started to do targeted biopsies, and in fact we will discuss later with Dr. Rees as well the importance of this, particularly in this field of active surveillance. So the next talk in a couple of weeks will be in regard of that as well. So that will be interesting to see how their experience has been and why we should adopt that for and to be offered to our patients in AS. So that is something that also it's a plus to the actual tool of AS in following these patients, isn't it, Adam?
Yeah, so I think one strategy, and again, many of our patients, because active or MRI is still relatively difficult to get in the United States as well. A lot of insurance providers don't want to cover it. So a strategy that we often utilize is, the diagnostic biopsy is often done without an MRI or without fusion technology. If they have what looks like low risk disease, they're put on active surveillance. But then the next biopsy, which we typically do somewhere around 6 to 9 months after the initial biopsy, that's when oftentimes we're able to get the MRI, and when we do the fusion biopsy. And so then if we find, upgrading to 3+4 or 4+3, that patient really probably hasn't been harmed by that 6 to 9 month delay. We find the higher grade disease with the fusion biopsy, we take them off of surveillance, we recommend surgery or radiation therapy. And we all know with, Gleason 3+4 or even 4+3, it's highly unlikely that they had significant disease progression during that 6 to 9 months, as long as their PSA was reasonably low. So that's a way around it, is you don't have to necessarily get an MRI on everybody, but in those patients that are already on surveillance and you're doing surveillance or confirmatory biopsies, that's where the MRI can be very helpful, I think.
Yep. So yeah, I guess that we all are well illustrated, and in order to be respectful of time, we're right on time for the closure. Again, giving many thanks to Alejandro and Adam for participating with us. We are all enriched and stimulated, and to continue on implementing this tool as well, the AS, and also to follow the recommendations and the per case as well, to be adapted to our countries and to our practices. And we'll talk later about that as well, so, because I'm pretty sure it's a great tool and will give us a more scientific base to proceed with. Thank you to all. Thanks for all the people who's participating with us, and we'll see you in a couple of weeks with a new topic. This time, Dr. Reese will speak about his experience as well with the MRI fusion biopsy and the follow-up of patients with on active surveillance as well. Thank you.
Okay.
Thank you very much, and see you very soon again.
Thank you.
Thank you.
Okay, bye-bye.